Tonight's featured presentation is entitled Crash, a Course in Cultural Competency. Morehouse School of Medicine is accredited by the Accreditation Council for Continuing Medical Education to sponsor continuing medical education for physicians only. The Morehouse School of Medicine designates this educational activity for a maximum of 1 AMA PRA Category 1 credit. Physicians should only claim credits commensurate with the extent of their participation in the activity. Tonight's presenter is Dr. George Rust, MD, MPH. Dr. Rust is a professor of family medicine and director of the National Center for Primary Care at Morehouse School of Medicine, a historically black institution where he has taught and led various programs since 1991. Before that, he served 6 years as medical director for the West Orange Farm Workers Health Association in Central Florida. He is board certified in both family practice and preventive medicine and is the author of over 50 peer-reviewed publications related to primary care, health disparities, and underserved populations. Tonight he's joined by Mr. Cesar Alvarado, a community advocate. Cesar specializes in primary prevention, advocacy, community health, and enhancing the delivery of culturally and linguistically appropriate primary care health services. Cesar has used his formal and informal education to support the empowerment of multicultural community members in Atlanta, the nation, and Mexico as they create and nurture concrete solutions to oppressions negatively affecting their holistic health. He supports healthcare providers via cultural competency and healthcare trainings and offers technical assistance to reduce cultural barriers. The goal of this session is to provide a framework of values and strategies for developing cultural competency in various settings. CRASH is a mnemonic for consider culture, respect, access and affirm, show sensitivity, self-awareness, and humility. This webinar will provide real-world examples and strategies for clinicians to apply CRASH principles in any setting. The presentation will be divided into 3 sections with a brief intermission. The questions will be held to the very end. However, participants are able to type their questions in the queue and we will hold them till that time. So let's welcome Dr. Rust and Mr. Alvarado.
Well, thanks so much for letting me be part of this program tonight, and we apologize for those sound issues at the beginning of the program, but I think we've muted one of the mics that is connected to that sound issue. I do see a question coming in about the CME and the CEU credits, so let me just go ahead and mention that although we are accredited for the continuing medical education programs and we'll have pending credits for the American Academy of Family Physicians, which will apply for physician assistants as well. The CEU credits for behavioral health counselors are still pending for this program. Please stay in close touch with us and we'll make sure that those credits are made available. But as of this moment, they are not quite confirmed, so we don't want to inappropriately suggest that they are, but we are working on that. We are aware that we have a very diverse clinical community that we're serving, and apologize again for not having that already available and able to offer that to you right at the very beginning of this program. I have no conflicts of interest to disclose, and we've just described the continuing education credits. Let me just go ahead and move straight into the crash course. We are sort of broadcasting here from the National Center for Primary Care at Morehouse School of Medicine, and happy to be here with you. And really wanting to affirm those of you that are in the field, in the National Health Service Corps, having been there myself and knowing what that can feel like. We are just very proud of all of you and the work that you're doing, and aware that sometimes it's very fulfilling and sometimes also can be very challenging. And the whole idea of this primarycareforall.org website is to provide support for you, both in the continuing education space, but also through the coffee house chats where the virtual community of National Health Service Corps clinicians can support one another. This crash course was developed with a whole lot of folks from a lot of different backgrounds and interests. and over time has evolved, but we think it provides a broad framework of principles for approaching culturally diverse settings in the clinical arena. Dr. David Satcher works here in this building. He's 16th Surgeon General of the United States, and he authored a number of Surgeon General's reports, but one of the most important was mental health, culture, race, and ethnicity. And in that report, the simple phrase, culture counts, was one that they used to remind us that although each of us are individuals, our cultural backgrounds make a difference in how we approach the clinical encounter and whether or not that's an effective clinical encounter for us. Here's an example of what I mean. To control diabetes, all you have to do is modify a person's health beliefs and attitudes, daily habits, eating preferences, daily activities, exercise, self-care, and medication adherence, all in the context of their family and social relationships. Now raise your hand if you want to do that all by yourself. If you think you can do that without a team or without being culturally relevant for the communities that you're serving. Jimmy Carter put it this way, we're not a melting pot, but a beautiful mosaic. It's not that other people melt into majority culture and lose their own cultural identity. Rather, whether we think of it as a tapestry and multicolored threads woven together into a beautiful picture, or whether we think about it, I like to think about it like a Snickers bar. You know, peanuts and chocolate and caramel and all kind of melt together in a gooey goodness, but each retaining their own identity. That's what we get when we value cultural differences. And frankly, there are some risks of cultural competency training. People think, well, I went to the workshop, I must be culturally competent now. Or we end up reinforcing cultural stereotypes by lumping a whole group of people as Hispanic or Latino. Cesar, talk to me for a moment about that. The cultural identities just within this large lumpy group that is sometimes referred to as Hispanic or Latino. Talk to me a little bit about the different layers of cultural identity and national identity and how people would self-identify.
Of course, most definitely. And those are delicate terms, definitely delicate terms. You mentioned Hispanic, you mentioned Latino. I self-identify as a Chicano. And there's a lot of differences, there's a lot of similarities. There's a lot of historical context. My father, an educator for over 35 years in a public school system, likes to be considered a Mexican American, and that's how he self-identifies. He's 73, so he's from that generation. But self-identity and asking the individual what they prefer to be, how they prefer, excuse me, to be identified is key. It's absolutely key.
Very good. Well, and we'll talk a little bit more about that after a bit, but that's one of the risks of these kinds of workshops is that we can end up lumping people into groups as if all African American people behaved a certain way or all white people behaved a certain way. It's also possible to focus on the exotic over the important. I remember in early conferences I went to about migrant health or farm worker health, and it seemed like all the talks were about TB and parasites. And it wasn't because TB and parasites were that common. It's really diabetes and heart disease that were killing a lot of my patients. But because TB and parasites may have been different from what people experienced during their training, they wanted to spend a lot of time focusing on that. And in the same way, we may end up talking about susto and caída de mollera and different culturally derived syndromes as if those are the most important parts of cultural competency, when in fact it may be that issues like respeto, personalismo, y confianza, in other words, personal relational trust and respect, are the more important issues that a clinician needs to take on.
If I may, Dr. Russ, I think that some of the issues that you're pointing across is the complexity
Right.
about cultural competency. And I may be somebody that teaches cultural competency and gives other people knowledge around the cultural competency that I've been given, but it's complex.
Right.
It's not absolutely simple. It's not absolutely simple, but at the base of that, it's not impossible to be culturally competent.
Well, with that encouragement, let's see what we can learn um, through the crash course. And I will just say one more thing. Cultural competence does not replace culturally diverse teams, culturally proportionately representative teams. In other words, having a group of individuals from majority culture just go through a cultural competency workshop and not hire people from the community of the community is actually kind of to create a not culturally competent organization. And you might as well acknowledge that race is part of this conversation as well. We have a history here in America. There's some stuff that happened that is part of who we are as a nation. Wynton Marsalis said race is the elephant sitting in America's living room that sometimes we don't talk about, but clearly affects so many of our conversations. So the crash course, Sabrina already outlined the elements of it, but consider culture, respect, assess, affirm, sensitivity, self-awareness, and humility. Let's go through these one by one. Now, I'm not a big one for academic definitions of things. This is one definition of culture, the integrated pattern of human behavior, including thoughts, communications, actions, customs, beliefs, values, and institutions of a racial, ethnic, religious, or social group. You know, that implies that that group has all of those things exactly in common, and that's kind of not true. But it is true that there are different norms in different communities, and the range of behaviors, the range of ways of thinking about something may differ from one community to another. Let's think about core culture in this way, that it's not just about white or black or Latino, but even within a group, if we say Asian, for example, that includes people of many nations, of many languages, of many religions, from many geographic regions. Even within India, we'll find individuals who are of very different religious backgrounds, who are from the south or from the north, who are Hindu or Muslim, who speak Gujarati or Malawali, all of which define a core culture for a community or for individuals in a family, but perhaps might be very different from one section of the country to another. Then on top of that core culture, culture is expressed through individuals. I'm not the same person my brother is. I'm not the same person my parents are. And so gender and age and whether I was the firstborn or the lastborn and our family dynamics and how dysfunctional we were and my own personal temperament, am I an introvert or an extrovert, all these things will affect how my core culture is expressed through me as an individual person. And it allows for a great deal of heterogeneity, even as we acknowledge that culture still matters and culture still does give me certain perspectives on how things work. And then finally, culture is expressed through individuals, but also over time. Hopefully, I'm not the same person that I was when I was 20. I've gotten married. I've tried to learn to become a father and a husband. I went to medical school and took on the MD culture. Some would say the MD personality disorder, but we learn a whole different language. My vocabulary grew substantially, and I use words like meningitis that as if people understood what those words meant. And so we all change over time. And you can imagine someone moving from one country to another country and how acculturation can really affect the expression of culture over a period of time.
One piece that this gets to, Dr. Russ, is that sense of community.
Yes.
My culture connects me to my community connects me to my culture. They're interrelated, they're interconnected.
That's right.
And it's very important because everything on this slide, the gender, the social status and power, the family dynamics, the education and vocation, everything, even inside that box, the race, the history, the religion or spirituality. In our case, we have to mention spirituality, right, because of the multiculturalism, multicultural communities that we work with. But all this makes community.
Right. And you know, we often use the word communities in plural. And so here in Atlanta, it would be not wise to describe the Latino community or the Hispanic community. There are many communities, as there are many Asian communities. I go to a little village in Honduras once a year and do some work, and there are Pentecostals and Catholics, and there are individuals even within a village that represent different cultural dimensions. And so we've called some of our workshops diversidades, just to show diversities, the layers upon layers of diversity within diversities. Well, when the California Endowment surveyed individuals in California about their interactions with the healthcare system and the thing that they wish providers knew about cultural dynamics, about cultural competency, about how they wanted to be treated in the healthcare system, the number one word that came up over and over and over again was respect. Individuals felt disrespected in the healthcare setting frequently, even though the clinicians did not at all intend for that to happen. And part of that issue is we have to learn how to demonstrate respect differently in different cultural settings. How my mother taught me to show respect is great for showing respect to my mother. But that may not be the way that another individual from another culture receives respect. And so I need to learn their way of showing respect if I want them to have a sense that I'm giving them respect, the way that they perceive it, the way they receive it. So we're going to show a little video clip here, and I want you to watch for 3 ways in which this doctor disrespects this patient in 30 seconds, and with absolutely no intention of hurting her feelings or disrespecting her. He's in fact wanting her to like him and wanting her to trust him.
Bessie, I'm Dr. Stevens. How are you doing today?
Very well, thank you. Can't complain.
Atta girl.
Well, what did you all see? What 3 things did this individual do that this patient may have interpreted as disrespect when the doctor didn't mean it that way? Called her by her first name as soon as he walked in the door. Hi, Bessie, how you doing? Reached out to take her hand without really asking permission. Called her atta girl at the end of it, not really recognizing the black-white dynamics of using the term girl with a woman old enough to be his mother, and then standing over and patting her on the shoulder, again touching without permission. So in at least 3 different ways, right from the very get-go, this individual has broken trust and caused a sense of distancing with a patient where his entire interaction was designed from his cultural perspective to create shallow intimacy, was designed to create an opening, a liking, an informality, and didn't realize at all that what he was doing was stepping right into the trap of disrespecting her. And I love it that some of you have already typed in the answer to those questions and gotten them right.
You said a really important term, Dr. Rust, permission.
Yes.
It's an invitation to share.
Right.
It's an invitation to this interaction.
And you know,
because this interaction is key. We're talking about, if I'm a patient, we're talking about my health, my wellness, how long I'm going to live, in all honesty.
Absolutely. One of the things that is on this next slide is asking permission before touching. And I've had some of the people that when I'm training say, you know, that sounds a little creepy. You know, if I go in the exam room as a doctor with a white coat and I'm interacting with somebody who's got a rash and I say, may I touch you? All right, I'll grant you, that sounds a little bit weird. I'll give you that one. But what I often do is I reach out my hand and I say, shall we have a look? And allow the patient then to put their hand in my hand. It's just a subtle thing, it's nonverbal, but I don't just reach and grab. Instead, I reach out without touching, offer my hand, and allow the individual to put their hand in mine, or to, if it's a rash, wherever it is, I might just say, shall we have a look? And wait for the person even to give just a nod or a nonverbal assent. But it's that little subtle, I'm asking permission. I'm not just reaching in and grabbing you and checking your pulse and invading your space without acknowledging you as a human being first. Using titles. Talk to me a little bit, Cesar. Doña Maria. What would that, what does that mean?
Doña Maria, she's everywhere. She's all over. She's in these underserved communities
Okay.
that these doctors are in, that
But that
these
term is a
doctors.
term of respect, is
It
it not?
is,
It
and
would be a way of saying, certainly calling her Senora
mhm.
Alvarez would, or, or something would be appropriate, but Doña Maria, if you're going to use that first name, putting the term of respect in front of it, and Don Pedro, or if you must use the first name, continuing to add that term of respect first.
Of course, and it's key. You, we all know that that first interaction,
Mm-hmm.
once the doctor or the social worker or that healthcare provider, that clinician opens that door or greets that person, that's when it all starts.
Right.
And if we begin with Mr. Gonzalez or Mrs. Gonzalez, um, that's key. That's really key. It shows that I respect you as a human being,
Mm-hmm.
and I'm not above you. I want to be as equal as possible to you,
Right.
with you, excuse me. And in my interactions as a clinician with my patients and my patients' family members, they eventually give me permission
Right.
and invite me to use their first name.
Exactly right. So you wait for that invitation. Of course, Spanish has a lovely way of doing this as well with the tú and usted forms of the
Mm-hmm.
language. I'll notice many of my Anglo friends quickly downshifting into the informal version of you when dealing with an elder that perhaps they should maintain the formality. It seems artificially formal to some people, and some of the American culture particularly tends to be a little bit informal. And we just have to kind of grit our teeth and acknowledge, okay, this seems a little extra formal to me, but I need to do it anyway. It's really important in these settings.
Sabrina mentioned Miss Sabrina mentioned my informal education. My informal education comes from my family members.
Right.
And my mom's mom, Mama Rosa was her name, used to detest me calling her tú.
Mm-hmm.
And she would tell my aunt and tell my mom after I left the room, he needs to call me usted.
Ah, and that's another key point, and we'll move on here though. But our patients will be too gracious and too polite to tell us when we mess that up. We may have individuals on our staff who can be cultural brokers for us, where we can ask and say, please tell me when I mess it up, because I know my patients will be too nice and too gracious to point it out. And they'll nod and they'll smile and they'll tell me what a wonderful doctor I am. But in fact, I may have offended and never realized it unless somebody tells me.
Mm-hmm.
Well, so showing disrespect, things we want to avoid doing. Again, using first name or nickname without permission, touching without permission. Sometimes people actually express disrespect explicitly, and I think without even realizing they're doing it. Somebody who says, well, you shouldn't have to ask your husband just to make a decision about taking the pill. It's your body, you know. Well, you've just entered into a fairly deep space of how that husband and wife interact with each other and how they make decisions together. And you've chosen to say that your values are more important than their values on that. So we kind of want to watch that and catch ourselves when we're doing it. Interesting, we have a comment from one of our participants from Alaska saying that we use a lower volume voice with native tribal folks, and the handshake is not used very much. It feels odd to some individuals in that culture, and that's great. We're in a learning mode. Teach me. How would I show respect in a way that your elders would receive it? Let your patients be your teachers in that space. Well, so that respect, I think we've made that point. So consider culture, show respect again and again, even if it means being a little bit formal, and then assess. Make an assessment of people's perspectives that may be different from your own. It may be health beliefs, it may be health knowledge, health literacy, but also health-seeking behaviors. In Chicago, in the low-income communities, we used to say, "Are you $10 sick?" And $10 was what it might cost you to pay somebody to bring you to the doctor, or nowadays it might be a copay in a clinic. And then health-relevant relationships. Kleinman has 9 questions. Actually, it turns out to be more questions than that, but he lists them in 9 lines. But trying to understand, what do you call your problem and how do you understand it? If you've not had the chance to read Ann Fedemann's book, The Spirit Catches You and You Fall Down, I encourage you to read that. It has a bit of a tragic sense about it because there's never an absolutely perfect connection between the clinicians and this Hmong family with a daughter who has a seizure disorder, who the parents understand to be having a spiritual moment during those seizures, and the clinicians being very concerned about the medical aspects of it, and them never really getting on the same page about what this is and how we should treat it. Let me ask the audience, and I'll wait and see if anybody types in an answer for this, but what's the diagnosis on this patient? Cupping. Good. Cupping. We've got a lot of very smart audience members on this call. So I will have to admit to you that I was not nearly that smart the first time I saw this. A patient from Poland, actually, before we had the Polish interpreter available to translate what was going on. I saw this rash. I was a medical student. The attending physician asked me to generate a differential diagnosis. I started coming up with things like erythema multiforme, and the whole time in my head, the words giant sucking squid were going through my head, and I said, I can't say that out loud to this attending. But yes, cupping has different meanings in different cultures, but it is common in several parts of the world, as a way to draw out the vapors, as a way to draw healing energies, to align the forces in the body. There's a lot of different ways of understanding it, but a jar is heated and put on the back, sometimes a clay jar, sometimes a glass jar, and really sucks a good chunk of skin and subcutaneous tissue up into the jar over a period of time. Doesn't hurt anybody, but it does leave these marks sometimes. A variation or a different thing that some of us lump as being having some similarities is coin rubbing. It goes by different names in different nations and different cultures, but again can leave some significant marks on the body, and if you don't know what you're looking at, it can be a little bit scary to look at. Nobody's ever really significantly harmed by this, but it does raise some marks that leave doctors and nurses sometimes a little bit concerned. Now, here's where I would ask you to think about, where are the cultural boundaries when, in your efforts to be open, in your efforts to understand and affirm people of other cultures, is there ever a moment where it's okay for you to set your own boundaries and say, you know what, I'm just not okay with this. As a clinician, I have a sense of what I can allow and what I'm going to have to step in and say, you know, this really isn't okay. You're doing coining on a child. It's leaving marks that are significant enough. Somebody's going to report you to child abuse authorities. We need to talk about this. We need to negotiate from where you're at culturally to where I'm at culturally from my medical culture background, if the patient is a child, for example. Here's another one. Oops. And this picture didn't load properly, but the tiny little picture up in the corner here is actually of a baby smoking. So all pictures of smoking in a culture where smoking is very common. We did some surveys actually in various Asian communities here in Atlanta recently, and one of the questions was, do you smoke? And the second was, do you think do you need help for quitting smoking, or does your community find that smoking is a problem? And at least in one community that we surveyed, 100% of the individuals smoked and 0% thought it was a problem or wanted help in solving it. But again, if the adult up in the corner, in the upper left corner, is smoking, that's one thing. If the monkey's smoking, that may be a veterinarian issue. Now, the parent who's smoking with the child in their arms, we're getting into a secondary smoke issue. And the picture, I guess it's hiding because it's so offensive. The idea of a baby smoking would be something where we'd probably have to step in and say, that's really not okay. And we're going to go ahead and have to confront that and negotiate around that a little bit.
Some of the people on the webinar might remember that the picture that's back there is the video of the baby in Bali, maybe about 8 months ago or so. So you can easily find that on YouTube. If you just put Bali baby smoking, you can see what we were trying to show you.
Right. Well, having some assessment, different people understand things differently. I've had any number of patients over the years tell me I can't have high blood because I've had low blood all my life. Obviously, we're talking about hypertension and anemia at the same time, but a conceptual framework of high blood and low blood is tough to sort out. And that's across all income levels and across all literacy levels. Different people have different sources of knowledge, but individuals will have ways of thinking about their illness. Now, another area to assess is language differences, and we're going to show you two videos now. One that involves staff members who speak two different languages and an encounter that they're having together. After that first video, we'll stop and talk about that one a little bit. And then we'll see a different twist on the same kind of issue. So let's go ahead and watch that video.
You hear them yammering in Spanish? Do they think we can't hear them? Probably talking about us. There ought to be a rule. Speak English. This is America. Crying out loud.
Es que es demasiados pacientes a la vez. Mira, esas pobres enfermeras han estado trabajando todo el día. No es posible, es demasiado trabajo. Esto está de locura. Esto está de loco.
Yo creo que loco. Hear that? They think we're crazy. Loco. I'm gonna loco him right upside his head. They don't stop talking about us.
So not an uncommon scenario in a lot of clinical settings. Individuals who speak two different languages, when you're serving a bilingual population and you have bilingual staff, it's not uncommon for people to shift gears into a language that they're more comfortable with. There are some rules of the road around that. Now, in this encounter, if you spoke Spanish, you'd understand that the folks in white coats at the forefront of your screen are actually saying just how hard they're working, how many patients they've seen in clinic that day, how it's crazy to make the nurses have to work that hard. They're actually sympathizing with the nurses who are in the background. They're feeling for them and describing how the system isn't serving them very well, and in fact, it's crazy. Local. Of course, most of us, if we're standing near somebody who's speaking another language and looking in our direction, our insecurities bubble up to the top, and before you know it, we think they're talking about us, and it must not be good. And before you know it, we're starting to think bad things about them because they must be talking badly about us. So this is not an uncommon scenario. What you don't want to do is overreact to it. There was a clinic in the Atlanta area, public health department director, who for a moment passed out a memo and a rule saying that all conversations in the clinic had to happen in English. And use the phrase to enhance communication. Well, that doesn't enhance communication. That actually makes it a lot harder for your limited English patients. But because of that sort of insecurity and desire to have everyone speaking a language that we understand, we sometimes overreact. Now, what would be more appropriate in this setting? Acknowledging that you're speaking in another language, why you're speaking that language, what you're talking about. If there are people who are overhearing you who don't speak that language, including them in the conversation and explaining why you're speaking in that language and why the conversation really isn't about them. Let's go ahead and look at the next video, though, and we'll see another example of how this can happen in a reverse form for the patients.
Hey, John. Busy morning. I heard you saw 17 patients.
Yeah, I've been kind of busy. I've seen a few flu cases and a few rashes.
Oh, you're so modest. You know you'll get that productivity bonus again this month.
Yeah, I guess, but let's not forget our quality program, which is focusing this month on cancer. Cancer screening is very important. Prostate cancer, and especially colorectal cancer. You know how it is. When patients come in with all the problems, you tend to forget. And male patients don't like us poking around.
But remember, it's not just men. Women are having pap smears and mammograms. But we're not sticking our fingers up enough rectums, you know.
Okay, now let me get back to my patient.
Okay, but don't forget. Today, the big word is cancer.
Okay.
But remember, when you see Mr. Lopez, prostate cancer screening.
Okay, let me get back to my patient.
And get that finger in that rectum. Remember, cancer.
Señor López, ¿cómo estás? Muy bien, perfecto, no necesito nada.
But you can imagine it was no fun being that patient in that moment. A patient who only speaks Spanish, who's listening to this hallway conversation, not understanding what the doctor and the nurse, or actually the two doctors, are talking about, hearing only one word that he understands, which is cancer, and going home that night and believing that perhaps his doctors think he has cancer and just haven't been willing to tell him. So in the very same way that when people speak Spanish in front of us or speak another language in front of us, and we wonder what they're talking about, we get nervous about what they're talking about, those of us who go around speaking English in clinic all day long have to have some sensitivity to what impact that's having on limited English proficiency patients. And again, be willing to follow those same guidelines, include them in the conversation, explain why we're speaking in English, offer an interpreter if needed, explain that someone will be available to speak with them in their own language, and explaining what the conversation is about would be appropriate. Well, again, assessing things, we're going to move quickly here through the rest of the assessment slides, but health-seeking behaviors, are you $10 sick, transportation barriers, locus of control. Do you go when you're sick a little bit, or do you wait till you're almost dying to go to the doctor? Those would be maybe examples of health-seeking behaviors that might differ from one community to another. Assessing practices that end up coming into the exam room, but that may have nothing to do with medical care, but you might kind of want to be aware of. So Cesar, we were talking about this at dinner tonight. The person who puts a gold band on their baby's wrist, or puts a beautiful necklace around the baby's neck, or puts a beautiful earring in the baby's ear, or even something on the forehead to draw attention away from the baby's eyes. What is that all about? Mm-hmm.
One word that comes to mind is special. It's special for these family members, for these people that use these these items. I've seen babies with just a red thread around their wrist. But it's about energy. It's about deflecting, like you said. It's also about personal space. And it's a little bit about being
And so from a clinician's point of view, if the doctor or nurse practitioner leans in really close, what a beautiful baby, I love this baby, the eyes are so pretty, and oh, isn't this a wonderful baby, and just continues to go on and on about how pretty the baby is, and looking directly into the face of the baby and so forth. In many cultures, that would be a compliment. That would be a way to tell the family nice things about their child, but in some settings may be perceived as that element of envidioso, and create a sense of jealousy and perhaps even have a spiritual dimension that might lead to a bad outcome for the baby. And again, parents may step in and be protective, or they may use these kinds of items to deflect attention from the baby's face or the baby's eyes. Great. Well, and so understanding that, letting our patients teach us about that, being willing to ask humble questions. And not just of the individual patient. You know, I think in our country with HIPAA, we are so privacy obsessed and so individualistic sometimes that
it's definitely spiritual.
Certainly when I was working in the migrant clinics, we learned very quickly that we needed to build clinics with bigger exam rooms because it wasn't just going to be one person in the room. We were going to have a family event. And that's how decisions are made. It's how health is worked on, is a together kind of familismo kind of way. And I can affirm that. It may be different than my culture. It may be different than the individualism that I enjoy. But being able to recognize positive values in other cultures and then reframe things. So one of the examples is in many parts of the world, Americans will perceive that other folks don't care that much about time. They show up late for appointments. You know, you say we'll come at 7 o'clock, but it's really, you know, 7:30, 8 o'clock, 9 o'clock before things get started. Showing up late for appointments can be a very negative thing from a provider's point of view, from a clinician's point of view. And yet, if we understand that an individual may be more relationally oriented, more people oriented, and not driven by tasks. When I was in Haiti, my wife and I were in Haiti for a period of time, and on a day when we were having fun and some of our Haitian friends wanted to tease the Americans a little bit, and they wanted to mimic or imitate an American, the imitations always involved sunglasses and a wristwatch. And their perspective was that Americans had been born with wristwatches surgically implanted, you know, before birth, because we were so consumed with being on time and getting tasks done, and so willing just to walk right past another individual if we were late for an appointment, as if relationships didn't matter. So I can reframe that in a way that says, you know what, those values are kind of better than my values, or at least I can see them in a very positive light. It's not just about them making my schedule get a little bit off because of they're not following my agenda. We all care for our babies differently. We've talked a little bit about this so far, but which is more different? Is it more different to put a little red thread on the forehead? Or is it more different to put your baby on a leash and take them for a walk in the shopping mall? You know, those both are behaviors that in one culture or another would seem different, would seem quite strange. Each of us are strange in our own unique ways, and recognizing that sort of, you know, if there's a cultural gap, there's two sides to it, and we each bring our own baggage, we each bring our own differentness to the equation. Sensitivity is probably the area where I think we have to do more learning about specific cultures, understanding what things might offend, what things are very unique to a culture, maybe because of history, because of ways of understanding certain things that, you know, you just don't do that here because it's offensive. It hurts people's feelings. So when the statue of Saddam Hussein was brought down in the square in Baghdad, what did people do to show their disrespect, their desire to be rid of that leader? In our country, someone might spit on it or show disrespect in a powerful way. In that setting, it was to take off one's shoes and hold them over the head of the statue. To show the bottom of the shoe to someone was the most disrespectful, the most offensive thing that they could think of to do. It's why President Bush had a shoe thrown at him and not a glove or some other object. And as a result, it means that if I cross my legs and the bottom of my shoe is showing to a patient, and I'm crossing my legs just because my back is tired, or I've had a long day, my legs are a little tired, and I'm showing my shoe to that individual, they are going to receive it as disrespect and somehow offensive, even if they know in their head that I don't mean it that way. Even if they know that I have no knowledge of that custom or that cultural sensitivity, even if they know that I don't mean to hurt anybody's feelings, it's still going to be a visceral response that is just very hard to get past. So we've got to learn specifics from cultures and ask our patients to teach us. History or politics or religious issues. There's racial issues in this country that if you don't know the history of a community, if you don't know that when you're advising someone to call the police for help, but that same police department was involved in lynchings that involved their family 30 years ago, 50 years ago, 70 years ago, and that oral history is still very well known in the community, and there's still some very strong sensitivities around that. You are going to step into some areas where, again, you need cultural brokers, people who can teach you, and people who are willing to tell you when you say something wrong. Patting a child's head. Who knew? That wasn't part of my culture, that it was wrong to pat a child on the head. But in some cultures that, again, may be invading their space. It may be a spiritual attack or in some way has the potential to bring harm to the child. And many parents are going to really tighten up, even though they may not physically stop you. They may suddenly feel fear or distrust because of that. I had someone explaining not too long ago that they had individuals in a certain Asian community who were offended because he would ask, well, how tall is your child? And he would hold his hand out like this. And someone finally explained that, well, in this community, that's how you measure the height of an inanimate object. If you want to ask the height of a living object, you say how tall and hold the hand this way. And just the difference between that and that was the difference between asking the question correctly versus asking the question that implied a dehumanizing of the patient. Mm-hmm. Mm-hmm.
One quick point, Dr. Russ, is timing. We're always in a hurry as clinicians. Not always, but most of the time we're in a hurry. And that's when
I think that's right. And it can be a challenge. You're busy in clinic. You've got to get to the next exam room. We used to start farm worker clinic mornings with 20 people lined up outside the door, and the rest of the day was just trying to, crank through the volume sometimes. And what I think maybe we need to recognize is that sometimes you're more time efficient if you invest a little bit in this stuff. My friend Roberto Danzi calls himself a recovering psychologist. He talks about the tortilla of the visit, that American physicians sometimes try to rush into the encounter and deal right with the meat of the conversation. How can I help you today? What are we doing for you today? How's your diabetes? And getting right into the meat of it. And he says, you can do that, but you're going to end up spending more time in the long run. If you ask, how's your family? How are you doing? Tell me about your cousin. Tell me, some kind of personal relational connection first. Then you'll have the opportunity to move into the meat of the conversation and move quickly through what you need to work on, but then end the conversation maybe with a blessing or maybe with a personal family touch of some type or another to again affirm the humanity of the individual. It ends up not taking that much more time. In fact, sometimes it saves you time. There's evidence that we as physicians, particularly, I'll own this one, we interrupt our patient within 17 seconds of the encounter starting. There's pretty good evidence now that if we just learn to be quiet for 2 minutes, even if you have to take an egg timer in the room and just turn it over and say, I'm going to listen and let the person get their whole story out for 2 minutes without interruption. We think that's going to make the visit go longer, and we don't have time for that. But in fact, it turns out we get better information, and the visit is not longer, in fact, can often be shorter, because the patient has gotten their whole story out, and then we can ask clarifying questions. And that really does make a dramatic difference without slowing you down or changing your schedule. You can do things later in the visit that are closed-ended questions and really make it clear that you need to wind the visit down. But at the beginning, if you can discipline yourself, just try it for one day. 2 minutes, take an egg timer. Every time you go in the exam room, or sneak a look at your watch if you have to, but force yourself. Listen until the patient gets their whole story out, or at least until 2 minutes has gone by. You'll find that you're not spending more time in the room, but you're having dramatically better relationships with your patients. Very good. Well, one of the comments that I'm hearing from the field is, please expand on cultural broker. What do we mean by that?
Just so you all know,
another term that sometimes uses cultural bridge person.
With Dr. Russ
And basically, this is not a professional role.
I'm
not looking in the yellow pages under cultural brokers. This may often be somebody who's on the clinic staff or in the community, but somebody who is bicultural enough that they understand my doctor culture or my Anglo culture, but they also are in and of the cultural community that I'm serving. And if I find somebody who's willing to stand in between those cultures and translate for me, here's how what you're saying is being interpreted. Did you know that when you sit that way, people think you're trying to rush them, or you're offending them in some way or another? Or did you know that when you shake Mr. Ahmed's hand after 3 o'clock, he's just gone in the bathroom to do his ablutions, and he's washed himself and washed his hands, and he's trying to greet you in a way that doesn't have you grabbing his hand, and as soon as you finish doing that, he's running back in the bathroom to wash his hands and his arms again. Having somebody who's willing to tell you that stuff and say, here's a different way you may approach this, and being humble enough to be a learner from your nurse's aide or from a community outreach worker, and let them be the professor in that moment. So being sensitive to things, we put these on the screen just to remind us that not every hand signal is universal. A thumbs up sign, an okay sign, a hanging loose sign, all these things can mean very different things in some countries, may be perceived as having sexual overtones, may be perceived as being aggressive or offensive in one or another, and we just want to be a little cautious about how we use those motions. And again, ask people to tell us. Some of our patients will be too polite and too kind. That's where we need individuals who are willing to tell us when our, as one friend told me, if somebody offers you a breath mint, they're not just being generous. And sometimes our staff members or our community members can teach us things. So learning to anticipate and being sensitive to cultural dynamics. We're not going to show this video, but it illustrates a scenario that actually happened in one of our hospitals here in Atlanta. A female family physician had been providing prenatal care for a woman for her whole pregnancy. She happened to be on vacation at the time the woman was getting ready to deliver and went into labor. Unfortunately, the only doctor that was available on call that night was a male resident. A male attending physician was backing him up, and the husband was not going to allow it. Was not going to allow that resident or the attending physician, either one, to attend to the woman's delivery. In that moment, there's just no good answers, to be honest with you. What are you going to do? Step behind the curtain and let the nurse examine her, or let the nurse deliver the baby and you shout instructions from behind her? There's just not a great set of options there. Transferring the baby to the woman and the baby to another hospital, just not a great option. Anticipating that need, knowing your community well enough to know that that may be an issue, talking about, I have 2 other people who share a call with me. One is a male physician. Is that an issue for you? Just having that conversation 3 months earlier would have headed this entire thing off. So here may be, I think, one of the most important pieces of cultural competency, and it takes years, I think, to work on this. It's not all about I'm normal and they're not. It's not all about minorities are different or individuals of another culture have these things that I find unusual. Fact is, they find stuff unusual about me. There's cultural baggage that I bring to the encounter. There are ways I think about time or task-oriented stuff or personal space. There are things that I consider normal behaviors, social behaviors. Ask in a very diverse setting, if a party invitation says 7 o'clock, the party's going to start, what time do you actually show up? And in different cultural settings, 7 o'clock may be polite or rude. If you show up at 7 o'clock in some settings and the party invitation said 7 o'clock, you're going to find people still in their robe cleaning up dishes in the kitchen because they don't expect anybody to get there till 8:30. Helping clean the dishes and get ready for the party. That's exactly right. And there are other settings where if you show up at 7:05, you're late. They already said grace and started serving the chicken wings. You know, I mean, there are very different cultural expectations around that. We're all different, and we all bring our differentness to the party. So be aware of that and stuff, particularly that we're especially sensitive about or especially tender about. Self-awareness also means being aware of our professional cultures, whether it's nursing culture or doctor culture. We have to sort of be self-aware. Let me back this up just a little bit. Medical culture, we tend to think that, here's a phrase for you, if it isn't written, it didn't happen. Well, my goodness, that just is silly. But in medical legal land, that's considered a true statement. Or the rest of you can wait in the waiting area, only the patient can come back to the exam room. That's doctor culture. That's not most cultures in the world. Being self-aware also about how we interpret stuff. We do this as a Rorschach test almost, you know, fill in the blanks as quickly as you can. My slides are jumping ahead of me here just a little bit. Apologize for that. But when people won't make eye contact with me, when I teach this session in some settings, and I ask people to fill in that blank very quickly without thinking about it, just what's their first instinctive response, you'll hear people say, well, it means people are hiding something, or they have low self-esteem, or maybe they're dishonest. In other words, we're assuming that we can see into someone's soul just on the basis of an external behavior. And in point of fact, eye contact can be very different in different settings. For an African-American person in Mississippi in 1950 to make eye contact when passing a white person on a sidewalk was just a scary, you know, not good kind of thing. It could lead to violence. And so, excuse me, people making eye contact can mean being honest and listening, or it can mean sexual aggressiveness. It can mean overt hostility. It means different things in different settings. So be aware that you bring your own interpretations to some of these things. And finally, I think where that leads us is to really be humble about all this stuff in our interactions. I've consciously been working on trying to become more culturally competent over at least 30 years that I've been aware of this. I can now clap on the wrong beat in any church in America. I will get it wrong each time. And it is different in different churches, I can tell you that. All of us have stuff to learn. We peel back layers of the onion, and every now and then a thought goes through my head, a feeling, a reaction to something that's just subconscious, and I think, oh, that's kind of ugly. There's a racist thought. There's a reaction to a situation that I didn't even think was in me anymore. And it comes up like yesterday's chili, just kind of, where did that come from? We have to be humble about this. We have to be willing to say I'm sorry in 1,000 different languages. We have to ask for our patients to teach us and allow us to become better learners and commit to a lifelong journey of learning. In point of fact, we are all as angels with only one wing, and we can only fly when we embrace each other. So I would encourage you, embrace your patients, embrace the communities that they live in, embrace the learning experience for a whole lifelong adventure of learning, and be humble about what you don't know. So thanks for that. And at this point, if there are other questions, we've got a few more minutes. We'll just take about 5 more minutes if there are questions or specific comments that folks want to make from the field. We really appreciate everyone who's participated. And yes, we will follow through on getting approval for CEU credits for all of the many wonderful clinicians and practitioners that we have from all the disciplines represented in the National Health Service Corps. Questions or other comments before we wrap up? Sorry, yes.
If I may, Dr. Russ, that last point that you said, and I don't want to take the floor. I want someone else to ask some questions, but it's very important to note that you weren't just talking about Anglo-Americans. We're talking about
that's a great
too,
point and very affirming. I think I just
and that as a clinician,
saw a question come across the screen. In what cultures can you not look in the child's eyes? As a pediatrician, that would be important for me to know. It's not that you can't look in a child's eyes. And Cesar, you may want to speak to this for just a moment. It's that sort of being overly effusive about the beauty of the child and just really sort of in their face about it, in their space, and looking in that way. That's probably, I think, what we're getting at here. Is certainly appropriate to say you have a nice looking child, or to look in the child's eyes with your ophthalmoscope and that sort of thing. But especially with a small baby, you'll find these sort of protective things. But Cesar, you want to say a word or two about that? Of course. Mm-hmm.
The word that I learned, and it was a difficult task, because in my training, I was trained first as a clinician, of course, but as a domestic violence advocate, as a sexual assault prevention specialist. So I learned about gentleness, and that's one thing that we're talking about. We're talking about being gentle with our patients, family members, at the same time being cognizant, being open to what their belief systems
and, you know,
are,
like you say, being quick to learn and maybe slow to scold. I heard of a women's clinic one time that had a no scold policy. I love that idea, but slow to judge, quick to sort of recognize, you know what, that may just be my baggage. I need to learn a little bit more before I wade into those waters. I see a question come across the screen. If cultural competency is something that's a lifetime journey, how can you tell where you are on this journey? I think number one, if you think you've arrived, go back to go and do not collect $200. Secondly, there are some stepwise, there's some conceptual frameworks and models that talk about cultural ignorance, to, you know, or being culturally malignant maybe is the worst zone, but then sort of cultural ignorance. I don't even think about it. You know, I'm colorblind, which I think Jesse Jackson said just means you're blind. You know, and then having more cultural awareness and then cultural knowledge. I don't know that any of us should ever really think of ourselves as culturally competent, so much as thinking that I'm continuing to learn. I'm maybe less culturally dysfunctional than I used to be. I've learned some skills and some knowledge that make me a little more effective in some cultural settings. And in other cultures, I'd be starting back at square one, but at least I'm more self-aware, and I can tell when my stuff is getting in the way of the encounter. Now, I do see a comment coming across, and I think this is not an uncommon sentiment, that we have to meet each other from both sides. Others should attempt to learn some American culture and so forth. And I guess I'm I get that sentiment, and I guess I would say that as a physician, as a health professional, I do have that mindset of going the extra mile. That it's that it's not my patient's responsibility to please me or to meet my needs. It is true that when they come to me, it's more of a relationship where I am responding to their needs and I have the opportunity to serve. So yes, as other individuals learn our culture, my patients over many years I think have very actively sought to learn, whether it's to learn English or whether it's to learn American culture and how it works and so forth. And I can't control that one way or the other. What I can control is how much I learn. And mhm. Right. It's a challenge, and that's one thing. I'm glad you brought that up because that's something you and I talked about that we wanted to make clear. There are some do's and don'ts in that space. One is always ask for an interpreter. You know, if you even think you need it, and if it's not available, you need to work with the organization to figure out ways to provide linguistically appropriate services. That's actually a civil rights regulation. There are some individuals who would say you always use an interpreter, you never use a friend or a family member. When they're adult patients and they bring an adult with them and they tell you, yes, I know you have medical interpreters available, but I would like my sister to interpret for me, there's some negotiation that can happen there. When they say, I'd like my teenage daughter to interpret for me, I think there can be no negotiation. It is a coercive thing for the child, puts them in a very awkward position, puts a lot of pressure on them. Many kids growing up in communities of limited English will describe just how scary that was to be interpreting in a medical encounter for one of their family members. So if there are any absolutes in this, I would have to say that's one of them is never use the child or a teenager as the interpreter in these situations. Well, with that, we are getting very close to the end of our time. I want to thank all of the National Health Service Corps clinicians, not only for their participation in this program, but for your commitment to serving the underserved, to standing in the gap, and really making a difference for health equity in this country. And I mean that from the bottom of my heart. What you are doing makes a difference and changes the health of this nation. So thank you for being there and doing that. Thanks for being willing to join us tonight for this program, and we hope it is part of your lifelong journey of learning about cultural competency. Sabrina, any closing words before we wrap this? Any closing words before we wrap this?
Yes, sir. I would like to also say thank you, ladies and gentlemen, for your participation in this webinar tonight. You really helped to make it special. I would also like to give a special thanks to Dr. George Rust and Mr. Cesar Everardo for an insightful and engaging presentation. Awesome thanks to our technical team, Mr. Quallen Hare and Jerry Robinson. Again, the Primary Care for All webinar series is made possible through a partnership between the National Center for Primary Care, the Association of Clinicians for the Underserved, the National Healthcare for the Homeless Council, and Clinician Directors Network, and also the Migrant Clinicians Network. This partnership allows Primary Care for All to serve as a resource for National Health Service Corps members and other clinicians who work in the underserved areas. Direct support for this webinar series was made possible with direct support from the U.S. Department of Health and Human Services, Health Resources and Services Administration, and the Bureau of Clinician Recruitment and Service. Primary